Yeah,
Yeah.
looks like it. Looks like it. So if everyone's happy, I would like to start the session. And first of all, welcome and hello, everyone. Um, Thanks for coming, joining us in this launch of the Nutritional Psychiatry Special Interest Group. We're looking forward to working with you and seeing where this collective effort could take us. And our aim is to create this collaborative space for sharing ideas, supporting research, and strengthening connections across disciplines. And today's launch marks the start of that journey. Our SIG brings together researchers, clinicians, practitioners, and industry professionals who share a common goal, which is advancing our understanding of how nutrition impacts mental health. We are so pleased to have you with us as we begin this exciting chapter. So this is what we are planning to do today. I will briefly introduce you to our nutritional psychiatry special interest group. And then we have three distinguished speakers, Professor Kuan-Pin from China Medical University, who will be providing his academic perspective on the topic. We have Dr. Christoph Killes from University of Roehampton. He will be talking about clinical perspective, and Dr. Caitlin Hall from Myota, who will be talking about industry perspective. And finally, there will be an interactive discussion on SIG engagement and next steps. So let's start with introducing the SIG. You all are aware that nutritional psychiatry is an emerging field that explores the intricate relationship between diet, nutrition, and mental cognitive health. It examines how what we eat can influence our mood, cognition, and overall psychological well-being, from the role of specific nutrients to the impact of dietary patterns. And this area is rapidly gaining attention as we face rising rates of mental health conditions globally. And while traditional approaches to treatment remain important, there is also growing recognition that nutrition may offer additional modifiable pathway to prevention and support. Despite this momentum, though, the field is still in its infancy with notable gaps. And hopefully within the SIG, we can talk and discuss about these gaps and how to move forwards. And that's where the new special interest group comes in. Our aim is to bring together researchers, clinicians, and industry partners with a shared interest in nutritional psychiatry. We will support the generation and dissemination of high quality evidence-based research in line with the Society's commitment to scientific excellence. We will be fostering networking, collaboration, and professional development opportunities across the disciplines, and raise the Society's profile within the nutritional psychiatry landscape. So briefly introducing the steering group members. I am Dr. Piril Hapsamali, and I'm Associate Professor in Psychology at the University of Reading, and I'm co-chairing this SIG with Dr. Daniel Lamport. Dan, would you like to briefly introduce yourself?
Absolutely. So thanks so much, Piril, and yeah, really excited to start this this group. And it's great to see so many familiar faces, and researchers, clinicians, industry partners all joining the call today. And I really hope that this is a chance for us to form collaborations and think about as a group where we can take this field forward, how we can benefit each of these stakeholders, not just about research, it's about the other elements too, the clinical and the industry side. So for me, yeah, really exciting. Can't wait to get this started. And this is just the beginning of something that we can all contribute to, hopefully. So yeah, and I think a lot of you know me, but yeah, I'm obviously Daniel Lamport, and I'm based at Reading. Yeah, that's me. So I'll hand over to Simon now.
Thanks, Daniel, and thanks, Pearl, for the introduction. Yeah, my name is Dr. Simon Dahl. I'm Senior Lecturer at the University of Roehampton. I lead the Masters in Clinical Neuroscience there. I look kind of at the role of lipids, bioactive lipids in brain protection and repair across the lifespan. And Daniel, you've kind of said it all, really. Just looking forward to today and getting to know lots of the new members and seeing what we can do with this special interest group.
Perfect. Catherine?
Okay, I'm Lars, so I'm certainly sharing everyone's enthusiasm for today's session. It's nice to see so many people. I'm a professor for developmental cognitive neuroscience at the University of Surrey, and I work on adolescent brain development, mostly as a critical window for brain development and plasticity. And this is also a time where diet and the microbiome and the social context all work together to shape mental health. So I'm approaching neuroscience, combining neuroscience and microbiome research and psychology for mechanisms that can help with interventions that can be done at the kitchen table. So I think this is a fantastic group, and I really look forward to see what we can create with this and what kind of synergies and collaborations are coming out of it. So looking forward to today.
Perfect. Thank you all. Moving forward, so our short-term goals as a SIG was to promote the SIG by creating the network of researchers, healthcare professionals and stakeholders working on this topic like yourselves. And within our first 6-month action plan, we wanted to organize the first online meeting, and here we are. But on the long term, our goals could be seen on the screen. We are hoping to establish national and hopefully in the future international networks and fostering cross-sectional sector partnerships. We would like to organize regular meetings, workshops, depending on the areas of interest of the members. We will also would like to focus on public and professional engagement to raise awareness about this topic among the general public. And hopefully we could act as a consortium in order to strengthen research capacity by leveraging a different diverse range of funding resources and facilitating collaborative grant applications. But anything else that we missed, we will be more than happy to hear your thoughts, and in the discussion at the end of this call, please feel free to unmute yourself or let us know, add comments, add chat function, use question and answer function, and let us know your thoughts really. And about the SIG I'd like to focus on a little bit about our membership now. We have more than 160 members, which is a bit shocking in a good way. The majority of them are from academia, and we have nearly the equal amount of industry and clinical representatives as well. The majority of our members are from the UK, but we have some international members, and ECRs have a good representation within our SIG, but hopefully this will grow as we grow. In terms of the expertise areas and interest areas, we have different expertise, as you can see on the screen. We have individuals who are more interested or experts in mental health and clinical applications. Some of our members are focusing more on eating behavior and public health. Some of our members are more focused on mechanisms, on gut-brain axis, microbiome and inflammation. And some members, their interest area is creating robust techniques, trials and methodologies. Certain members focus on special populations and life stages, such as children and adolescent nutrition or women's health, and even space neuroscience was mentioned. And finally, some of our members are experts in advocacy, impact and knowledge translation, which I believe is very important for us to translate the research information into practice. So about today's event, you know that the theme is nutritional psychiatry through multiple lenses, insights from academia, clinical practice, and industry. And we will explore the field from three distinct yet very complementary perspectives. And we will have Professor Kuan-Pin presenting the academic perspective, and his session will be moderated by Dr. Simon Dial. Dr. Christoph Kales's session will be moderated by Professor Catherine Cohen-Kadosh, and I will be moderating Dr. Caitlin Hall's talk. And each speaker will present around 15 minutes, and there will be 5 minutes for questions and answers. And without further ado, I will stop sharing my screen, and I'm handing over to Simon and Professor Kuan-Pin.
Thanks, Piril. So when we were setting up this inaugural event, kind of top of my list of speakers was Professor Kuan-Pin, and he's kindly agreed to speak. So it's my great pleasure to introduce Professor Su. He's professor at the College of Medicine, China Medical University, deputy superintendent at the Annan Hospital, and director of the Mind-Body Interface Research Centre. He also holds an honorary faculty position at the Institute of Psychiatry, King's in London. Professor Kuan-Pin's focus is on translational brain research, connecting bedside to bench using innovative approaches such as AI, neuroimaging, and genomics. His significant contribution in the field of omega-3 fatty acids is opening new therapeutic strategies and has provided major insights into the biological mechanisms in depression. He's a founding committee member and current vice president of the International Society for Nutritional Psychiatry Research. Professor Su is now also leading the new official journal as editor-in-chief of Nutritional Psychiatry. I don't want to embarrass him by going through the list of numerous awards he's been given, but I'll just highlight a couple. He's the Professor Robert Kerwin International Award from the British Association of Psychopharmacology in 2008, and twice ran the International Society for the Study of Fatty Acids and Lipids New Investigator Award. So without further ado, I'd like to pass over to Kuan-Pin. And
yeah. Thank you very much, Simon, for your warm introduction and your invitation. So I am now sharing my slide. Can you see the slide?
All good.
Good. And can you hear me well?
Yep, we can see and hear you. Thank you very much.
Very good. Thank you. So thank you for having me in this special interest group for the Nutritional Society. So today I'm going to share my research and clinical work about this topic and encourage interaction and some debate maybe. So before I start my talk, let me briefly introduce myself and my team. So my background is a psychiatrist, and I work with patients with depression for almost 30 years. And I also lead the Mind-Body Interface Research Center, the MBI lab, and also the first depression center in Taiwan, focusing on translational research and integrative care for depression. So this is my disclosure of conflict of interest within 5 years. And this talk will focus only on academic and professional discussion, and will not involve any specific product or recommendations or non-academic purpose. So this is today's outline. I will start by challenging traditional first-line drug treatment for depression and explore the potential application with nutraceutical as a first-line treatment, first-line approach, and emphasize the important role of shared decision-making, the SDM, between doctor and patients. And just to let you know, I'm happy to share to provide today's slides. So contact me or Simon for a copy if you need. So a major depressive disorder is a major global health issue affecting 1/4 of world population and lead the cause of worldwide disability. And so only 27% remitted after 14 weeks of first-line antidepressant drug. And after 1 year of 4 label treatments with combination of choice of 10 drugs and psychotherapy, up to 1/3 of patients still remain ill. And despite of the medication limitation, most patients are still mainly treated by medication. And we psychiatrists still rely on trial and error practice without any reliable biomarkers to choose the right treatment for the right patients. So the lack of reliable diagnostic system and treatment predictor make it imprecise, not only for psychiatric disorders, but also for many complex disorders. So this is a 2015 Nature article listing top 10 best sold drugs in the United States. And the fifth here is duloxetine, is Cymbalta, a very commonly prescribed antidepressant drug. And you can see the blue out of the red is the idea of number needed to treat to produce one difference as compared to placebo in the randomized control trials. So you can see the larger number of NNT, the more red means the smaller treatment effect. And you may wonder how these drugs with so small effect size, so large NNT, could get FDA approval and become so commonly used. And it's because that the big pharmaceutical company invested huge money in huge clinical trials with huge sample size in order to detect the very small statistic signals between drugs and placebo. So this idea of NNT is more useful than p-value when the placebo effect is significant. So take duloxetine, for example, with NNT of 7 to 9. And if you conducted the RCT with sample size of 300, then you probably can get the statistic value of 0.028 according to the power calculation and successfully get the FDA approval. However, if you conducted a RCT with only 200 subjects, then the drug trial might be failed. So it's not just the treatment to work or not, it's really the right study design to make it work. And it's very important to truly understand the clinical trial to interpret the result for effective drugs under the context of placebo effect. And there are some very important papers, for example, by Kirsch in 2008. He clearly showed that in mild to moderate depression, antidepressant only show very little or no difference to placebo. And the 2010 Fournier's paper further confirmed that finding. Despite of some medication supporters try to defend medication after Kirsch and Fournier's papers, but almost all the large-scale meta-analysis have reached similar findings, similar conclusion, including this paper from NEJM, from JAMA, from BMC, from BMJ Open. So the difference between drugs and placebo is really very small, and the efficacy of antidepressant drugs is often exaggerated. So you may say I am anti-medication, but I am not. I am actually a supporter of psychopharmacology, and my PhD is actually on psychopharmacology at King's College London. So I have no doubt that medication must be the mainstream approach because it's based on high quality clinical trial and strong foundation in molecular mechanisms. And its impact is scalable and is well regulated by government and medical societies. And it's actually covered, usually covered by insurance, so the patient don't need to pay. So please understand that my major concern here is not medication being mainstream, but it being only option. So it's not good for complex disease like depression to have kind of only option, only treatment here. So placebo has strong antidepressant effect, but it's not ethical. It's not ethical to prescribe placebo. So we need better option with strong evidence in efficacy and safety. So now let's explore the potential application of nutraceuticals as the one of the first-line approach. So our focus today is omega-3 fatty acid. And we all know that omega-3 is important in depression from several lines of evidence, including this famous epidemiological study by Professor Hebron in 1998 in Lancet, showing countries with high fish consumption to be associated with lower prevalence rate of depression, implying the protection effect of omega-3. And consistent to epidemiological studies, several case control studies reviewed lower omega-3 levels in depressed patients. And we published this first meta-analysis to confirm both EPA and DHA levels in depression are there's a deficit in omega-3 metabolism. But we all know that epidemiological study or case control study don't provide causal effect relationship. So we need gold standard evidence from RCTs. So in 2003, my team published one of the first RCT to show that omega-3 is better than placebo in MDD. And in 2007, we published the first meta-analysis to support omega-3's antidepressant effect. And in 2012, we updated the meta-analysis in molecular psychiatry. And we further found that antidepressant effect is mainly from EPA rather than DHA. And because of the property of EPA seem to link to anti-inflammation. So we started to think about personalized treatment of using omega-3, especially EPA, in inflammation-related depression. So there's a very important theory about depression is inflammation theory. And for several years, my colleagues and I at the NBI lab have been working on this topic in a translational way. For example, we found that patients with major depression, including perinatal depression, interferon alpha-induced depression, or cardiovascular disease comorbid with depression were associated with low omega-3 levels, and also some genomic and functional biomarkers in several case control studies to demonstrate the pathological effect of omega-3. And we also published some important clinical studies and meta-analysis to demonstrate the therapeutic effect, including the population that I just mentioned, interferon alpha, perinatal, patient with PAN, cardiovascular disease, or metabolic diseases. And we also apply human depression model in interferon alpha-induced depression and perinatal depression, and also some animal and cellular models to investigate the biological and molecular mechanism regarding to omega-3's antidepressant effect. So this slide summarizes our work in this field, but I don't have time to go through the detail. But you can actually scan the QR code or ask for a copy of the slide to read our other research. So now we see 2 or 3 new placebo-controlled trials published every year regarding omega-3 in depression, and maybe more new meta-analysis. And this is the most recent one in June. So the author included 36 placebo-controlled RCT, totaling more than 3,000 participants with MDD. And the results show that omega-3 are effective in depression, especially in especially EPA at a daily dose up to 1 gram per day for mild to moderate depression. And most importantly, omega-3 seems to have very, very little side effects. And indeed, these findings consistent to previous studies. So despite growing evidence supporting the antidepressant effect from omega-3, but their use in clinical setting is really is not widely accepted. So how do we bridge this gap? So what are the barriers? So let me compare the difference between the top sold antidepressant drugs, duloxetine, to omega-3 from several perspectives. So regarding clinical and basic research, as you can see, there's maybe their effect size are similar, but omega-3 actually have more preclinical research to support, because the academic society like to do the basic mechanism to support omega-3's effect. But the major difference lies in the quality of clinical trials. So pharmaceutical companies like Eli Lilly invested huge money into some large, high-quality RCT, but academic researchers only conducted RCT with mixed or poor quality in very small-scale studies. So that leads to inconsistent clinical results and make it difficult or hard for doctors to trust or to recommend this treatment. And for other practical application and regulation, as you can see, when doctors prescribe a drug, they don't have to worry about drug's quality. But with omega-3, clinicians really know very little about some reliable or high-quality products. And also drugs are approved by some drug and food regulation and promoted by both academic and also the pharmaceutical company, and also included in official clinical guidelines. And omega-3, on the other hand, are considered off-label use, and there's no incentive for promotion and very few guidelines to support their use. So we say even great medical research is useless if it doesn't reach patients. And it takes almost 20 years, 17 years in average for a new scientific finding to be implemented in clinical practice. So we need implementation science to identify the barriers and facilitate the transition. And this is where the academic society come in. For example, our Taiwanese Society of Nutritional Psychiatry Research, the TSNPR, try very hard to create clinical guidelines, to hold academic conference forums and educational workshops, and also actively collaborate with academia, healthcare, industry, and even policymakers. And recently, we published a special issue in the Psychiatry Annual Journal and featured some articles on latest advancement in nutritional psychiatry and to promote this implementation science. And just to let you know that our efforts at the TSMPR are actually making difference. For example, after the society is founded, and the official guidelines were established, Taiwan's fish oil imports actually increased unbelievably by 15 times in 5 years. So it's really a very good promotion from this medical academic society. And in 2013, several
One more minute, Kuan-Pin.
Sorry?
1 more minute.
Oh, sorry. So we got...
Thank you.
Okay. So let me skip some slides. Just invite you to attend to this year's International Society of Nutritional Psychiatry Research in 2025 in Taiwan. And we are hosting this event in Taipei. And also just mentioned by Simon that we are publishing our official journal with Elsevier, the Nutritional Psychiatry. So please come to join us and publish with us. So this is the guideline. I like to skip that. You can scan the QR code to read the details. It's chosen as an editor choice with free access in the Journal of Psychotherapy and Psychosomatics. And these are some brief description. We kind of emphasize the assessment, the comprehensive evaluation, and we emphasize the quality of product. And we also agreed on some special population, including perinatal and children patients. We recommend the formulation and dosage. We emphasize the adverse effect, and we also propose some future direction. And this is also a recent guest edit special issue in Psychiatry Annual. So I wrote an article about using nutraceutical as a first-line treatment in mild to moderate depression, like the topic today. So let me finish with some practical application. So the key is to engage the patient in shared decision-making process, where the clinician discuss all possible treatment options with the patient. So according to the NICE guideline from the UK, the management of depression should emphasize the SDM, the shared decision-making process. And it's very important not to offer antidepressant medication routinely as the first-line treatment, not only for the young patient, but also for the adults. So the idea of shared decision-making, the SDM, is a fundamental shift in modern healthcare. It moves away from traditional top-down approach where doctor make the decision. And the goal is to combine the best available medical evidence with the patient, with patient's preference. And also the process include team talk to establish the partnership between care team and the patient, and also the option talk to present pros and cons for potential options, and also decision talk to work together to reach a decision for final treatment option. And it's based on knowledge, communication, also respect. So let me conclude. So we explored how omega-3 fatty acid, especially EPA, offer promising first-line option for mild to moderate depression, and challenge the traditional idea of using only drugs. And we also, I also introduced implementation science and see how this implementation actually produce some real impact. And finally, I emphasize the shared decision making to ensure patient and doctor collaborate and tailor the treatment and bring the new treatment option into personal needs for more holistic or patient-centered care. Okay, that's it. Sorry for a bit delayed of the time. So I'd like to acknowledge my team, the NBI, and also the founding body and my collaborators. And thank you very much for your attention.
Thank you, Kuan-Pin. That's excellent talk. And maybe one day we can ask you back and give you a full session where you can fully expand on all these wonderful topics. Do we have time for one question, Piril?
Yes, yes.
Okay. So we've got time for a quick question. If anyone has a question, either put it in the chat or raise your hand. While people are thinking about this, so you've kind of touched on the issue of translating the research to the clinic. How long, how do you think we can help bridge that gap? How can we get the information better across? Because obviously there's statements from the ISMPR, and we're working on a statement from ISFAL about the evidence base. So how can we get the clinicians to engage better? Have you got any thoughts on this?
Thank you, Simon. I think it's really very crucial for us to promote this field. So my experience is that the society, for example, the special interest group and the society is very important. And I think the guideline, the clinical guideline is also very important for the clinician or for the health caregivers to have a base supported by the society. And I also think working with industry is very important because they need the motivation, incentive to develop a high quality product in a clinical application. So I think these are very important to shorten the gap.
Lovely, thank you very much. We'll take one question from Christina. You've got your hand up. I can't see your surname, sorry. Christina?
Okay, sorry. Yes, I was wondering, since EPA has been shown to be useful to reduce depression due to its impact on inflammation, is there any role for DHA itself in depression treatment, especially given its role in membrane integrity?
Thank you. I think this is also a very important question, because we think EPA might be a good evidence from current RCT, because we didn't see the head-to-head comparison study to show DHA's effect. But we need to keep in mind that all the RCT now is actually for adults. And we still don't know yet if maybe DHA is better than EPA in children or also the elderly patients. And we also know that most of the RCT are conducted in patients with drug resistance, which means there are some subgroup with higher inflammation. So we need more clinical trial to look at the head-to-head RCTs. And we also found that EPA is not detectable, almost undetectable in the brains. So the answer might not be the EPA itself. It might be the EPA-derived small molecule in the brain. So these are some important research we need to investigate.
Thank you. Christoph, I'll give you the last question.
Yeah, that's a tiny methodological question, but research in inflammation tend to divide type of depression now, where do we have inflamed induced or related depression, and we have depression that are not associated with inflammation. I guess it's between 20 or 30% of inflammation-related depression, and these are resistant most of the time to antidepressant and psychotherapy intervention. So I was wondering if there are like some LCTs or some more research that divided these two, as you were kind of mentioning it at the end of your answer earlier, just to see the target effect, if it's like through inflammation directly or if it's on both aspects.
You are right. When I mentioned personalized omega-3, especially EPA in depression, we actually targeting this subgroup. For example, the treatment-resistant, drug-resistant depression tend to have higher inflammation status. And we are also interested in patients with cardiovascular disease or patient with pain disorders or patient with more somatic symptoms in the phenotype. And these are also all population kind of linked to inflammation theory of depression.
Thank you. Thank you, Kuan-Pin, for a wonderful talk and for opening this inaugural meeting. I'll now pass over to Pyrrol. Thank you very much.
Thank you for having me. Thank you.
Thank you both. Thank you both. The next speaker will be Dr. Christoph Kless. I'm just trying to give him control.
And just while you're doing that, Pyrrol, I was just going to say that in the discussion session at the end, there might be a chance for us to just cover some of the other questions that have been put in the Q&A chat as well. If the speakers are still here, of course, but yeah, so we may get to those.
That's perfect. Can you still see my slides?
No, I can't see your slide currently, Pyrrol.
I can see them.
You can, Catherine?
Yeah.
Yeah?
Oh, yeah. No,
yeah, perfect. And Chris, I believe you can move the slides, and I'm leaving it to Catherine's capable hands.
Thank you very much. It's my pleasure to introduce Christoph Kless. He's a clinical psychologist and senior lecturer in psychology at the University of Roehampton. His work bridges psychology, psychoneuroimmunology, and clinical practice, with a particular focus on inflammation, depression, chronic kidney disease, perinatal mental health, mentalization, and inequalities in psychological support. He has published extensively on topics ranging from the psychological impact of episiotomy on to systematic reviews of depression in chronically ill populations, combining his clinical insights with larger dataset analysis and qualitative approaches. I'm very, very much looking forward to his talk, and yeah, looking forward to your questions as well. Thank you very much.
Yes, hello everyone. I'm very happy to be a part of your group today to make a presentation about the perception and awareness of mental health practitioners regarding nutrition-based strategies in the treatment of mental health conditions. So the original ideas stem from the work of Crystal Coxon, and I think she's a part of the group. And I think it, even though I'm communicating about it, I just wanted to mention as well that it's something that Crystal thought and developed initially, and then I have been collaborating to it. Let me try to find how to change the slides. I guess. Yes, I think it works. So the way the presentation will be done, I decided to make it a bit interactive because I asked some colleagues, whereas they are in France or in UK, what do you know? What do you think about nutritional psychiatry before doing this presentation? I wanted them to have like a sort of spontaneous feedback. And my first questions were, what do you know about it? and what would be like the research or the thing that you could tell me about that could influence your practice. So I will have like 2 first slides that look a little bit like, of course, obvious, but it's just because these are like the way clinicians actually told me about nutritional psychiatry. Then we will explore the need to exploring how this is this knowledge is penetrating like the field, especially in mental health profession. And we have launched a preliminary work with Crystal Coxon. I wanted to share some preliminary results. But on top of that, I wanted as well to provide a clinician perspective about what could be a challenge, but not in terms of knowledge, but the next step. So I will try to make it interactive if there are like some question about it. So the first thing is like today we know that there is an emergence of consensual results in nutritional psychiatry, and it has been nicely presented in the former presentation today. However, how this emergence of consensus is like going in the clinical perspective. So when I ask my colleagues, there were psychologists, psychiatrists with whom I worked in France, because I worked as a clinical psychologist for like 8-9 years in France. I have to say, I saw various answers. Some colleagues were like, this is absolutely not something I have heard about, even though they were chief of department in psychiatric hospitals. They were like, okay, maybe it can be good, but they were seeing that as a sort of side notes that you can actually have. And other people that were a bit more informed, and I would say younger in terms of age. This is very like spontaneous when I say that. They were like, yes, we have actually, sorry, it wasn't supposed to go there. Oh, I don't know why it's going, sorry. I don't know why the slides changed themselves. So yeah, they were like, yes, I've heard about it. But most of the time they were giving me like some feedback about general articles in the Times or in Le Monde in France, for instance, where you have like some discussion, but it's vulgarization article, which was a bit surprising because I was like, have you ever heard of like a study? And very few mentioned the SMILES trial, which is pretty old compared to everything that has been done since. So and the way they were saying it, and I created this this infographic, just like they were struck by the idea that the social support control group was actually showing a less important remission rate. Whereas, and the difference in percentage, they were not going in details and understanding everything, such as inflammatory pathways. They had like a sort of simplistic perception, whereas they were saying, okay, intervention, result. And this is something I want to talk about at the end of the presentation. The various pathways and mediating effects and everything are not in the clinical mind directly. This is something maybe we will have to work on, and that's where I want to go. So second, I had like 1 or 2 person that were telling me about this effect of omega-3 or EPA on different severe mental illness, SMI. And then I have to say it was like only 2 person that mentioned it. And when I was mentioning this result spontaneously, they were, it's not possible. This is a chronic illness. How this can have an impact. And this is where I think it's important. So you can see, like, of course, the effect size in between. So let's go fast to the other point. And this is something I wanted to talk before, and we have a lot of conversations sometimes with Kristen on this topic. The thing is, like, no, research has shown that nutrition and diet have a direct impact on the 3 levels of mental health. The first one is psychiatric disorders. This is our DSM or ICD-11 categories for mental psychiatric disorders. They are all well known. And actually, we know that they act as a mediator sometimes because there's like the behavioral aspect, but they also directly impact the psychiatric disorder through different pathways. I will not go into details. This is not fully my specialty, and I prefer like people that have been like the research themselves talk about it. So yeah, But we know that there is a direct and an indirect impact on psychiatric disorders. However, there is another aspect, which is the psychological distress. It corresponds to everything that is not a diagnosis, but still improvement. For instance, mourning, the anxiety when it's not diagnosed because you feel anxiety, but you don't have like the 6 months of general anxiety, or, you know, this is like all the subsymptomatic expression of distress. All of this, we know that there is an impact, and it acts as well as a mediator. And I think it's very important to mention that these are actually well more understood and taken in account. So when I asked my colleagues, they were like, "Oh, I'm sure it can work on distress or when you feel low or something like that." They have like this idea that it works on psychological distress, but it doesn't. They don't have it on psychiatric disorders. And when I put psychiatric disorders, mood disorders are part of it. Depression and anxiety disorders are psychiatric disorders. You can have anxiety without having a disorder. You can be very affected, having a low mood without having depression. And this is actually acknowledged by clinicians. They were like, yeah, of course it might work. So I was thinking, it might be a door to get in, and to think about that. And then there was the other way, where it's like the most agreed and understood. It's like nutrition and diets actually protects you and makes you having a better well-being in general. And there was a consensual approach. So I started to believe that it would be like interesting as well to target like the way the intervention could be like seen by mental health worker, depending as well on their objective. Because if you work as a psychologist somewhere and you are here to protect the well-being of someone by having primary prevention interventions, for instance, you will actually maybe more prone to think about that because you will target positive mental health and well-being. Whereas when you have more a secondary or tertiary prevention strategy and you target at a psychiatric disorder by specific treatment and specific approaches and therapeutics, then it looks like a bit more embedded in the way the clinicians were thinking. So that's was something I wanted to provide first as a sort of insight that came from my discussion with it was like 10 or 12 colleagues that I called over the last 3 weeks, just to know a bit what they were thinking about. So then we in this context, I decided to go a little bit online to find what we could find in English language about nutrition and mental health. And it's on vulgarization articles, but still with a good scientific background. So I found 3 slides, and you have like the reference. It's nutritionalpsychology.org. And I was very happy and curious to see like these results because they are actually in line with what I wanted to present. So you have 3 studies. They all have consensual feedbacks about the fact that most of the people are not trained or didn't receive any training. So it's between, how can I say, 50 to 75% of people that are not trained at all in nutrition. And however, you can see like a lot of people actually talk about it and use it in practice. It's like more than what I thought. And most of people want more training, which actually show that some people are a bit aware they don't have training and they actually want it, but still they have to talk about it, maybe because patients are making them talking about it, because this is like often a pathway that has been isolated. And I saw another aspect come from a research led in 2023, and it was a survey question where they actually asked the distinction between dietitian and psychologist, because I liked this infographics. It's very useful sometimes. And I was thinking, like, for instance, psychologist thinks a lot that diet discussion is in a psychological scope of practice, whereas dietitian doesn't. So it shows as well discrepancies between professions. And you can say that psychologists discuss on this study might be biased because the people that participate to this study, of course, might have been like aware of this. But they actually talk the link between diet and depression very easily, whereas the dietitian doesn't go there. And it would be nice to see if nutritionists and other profession do that. It's very interesting because it shows that dietitians limit themselves, but psychologists don't, whereas psychologists don't have the training, because this is what we've seen earlier. So we cannot exaggerate that, but we could expand the idea that there is no training and there is no specific information in the mental health profession, generally speaking, except for people that want to be informed. But still people are going and they're actually actually addressing it. Sometimes they refer, but sometimes not. So they're maybe some trend to address. So that's why I wanted to finish last thing. We have as well some result of a last recent study. It was questionnaires where the barrier and challenges have been addressed. But everyone recognized, of course, the importance of nutrition and mental health, but lack of time, knowledge and access to nutritional services are seen as a barrier. 50% of clinicians, 54 actually rate the knowledge of nutrition psychiatry as low. A lot of people would attend actually training, and 43% reported no education. So that's still the same trend, and that's still a barrier. So with Crystal, we decided to launch a research study. I'm very happy of my AI generated image. I wanted to put the picture of Crystal, but the AI didn't want. So the blue shirt and the person with the form is actually Crystal and I, made by AI. Well, they didn't accept our pictures to make it more real, but it could have been very nice. So this is a study. The objective was to explore the knowledge, opinions, and attitudes of UK-based mental health professionals toward nutrition and mental health. So we set some focus groups. We've done 6, I guess, or maybe 7. I don't remember because we just made them. And some were online, some were face-to-face, because some have been in a psychiatric institution that have partnered with us, and some other were in other mental health setting. So that's important to mention. We had, of course, made some specificities before. We made a sort of preliminary research, and Crystal has done it, where we identified and the gaps, the needs, and what has been said in literature, scientific literature. Then we've done a non-directed focus group with 5 mental health practitioners, and we asked them what were the views to grasp the last remaining themes and aspects that haven't been talked by colleagues. And it was very nice because people were authentic, saying oh, I don't have a clue, this is not my this is not my work. So it was very, very raw in terms of experience, and we built a semi-structured grid of interview that we used in the focus group. So we both, myself and Crystal Coxon, worked on doing these interviews. We worked and trained to run focus group together. We exchanged this. It was extremely nice. And we collected video and audio recording, and of course ethical approval was granted by Roehampton University. I don't have the number because I couldn't find it on my emails, but I can give you that anytime. I will need a bit of minute for it.
Sorry to interrupt, but my timekeeping rule. I think I have 3 minutes left.
That's perfect. Okay, so we've done a thematic analysis, and this is the way it's done. This is just a method one. But no, it needs to what is important and interesting. These are preliminary results. So we found that most of clinicians actually mentioned that there is a consensus on nutrition critical role. Though this role is more deducted than rooted in evidence-based practice, most of the time people don't know exactly what they are speaking about. They know that there is an effect, but they don't know exactly through which pathway it goes, except people that have been specifically trained there. I think this is important. So there is a sort of idea that it's good to work with, a sort of trend, but there is no evidence-based knowledge. Then there are some barriers and challenges, because even though it was positive, some people could bring some results, of the use of nutrition, but it was like patient-led. So it was like someone trying something and then coming back with like good results. So actually the patient make the changing practice more than the professional themselves from the preliminary results. And I think it's a very good point to mention, where we know that it's 15 to 20 years for getting changing practice. We got actually noticed like a confusion between diet and nutrition. Most of clinicians actually do not really understand. They confound intakes and quality of intakes, frequency, and what is in, because actually, I guess there is no evidence-based research, there is no knowledge about the pathway and everything. So these would help clarify diet and nutrition impacts, but this is not there yet. So there is no standardized evidence-based training. A subjective understanding of the notion of nutrition and diet is the most prevalent thing we observed. There are some systemic constraints impairing nutritional care, so shortage of specialized staff. So even though people have training, they would like to have like some colleagues that could actually be a referee or someone that to talk with on this type of topics. There are budget limitations for patients. It looks like when you don't have that much money, it's something that you would not be told to change your way or your dietary intake or your nutrition, because there's sort of, you know, the idea that it could be like impactful. And then also in quite training and education, most of people say, I don't even like have had a discussion like that in my training tool. And that was extremely like surprising. There are also reliance on self-directed learning. In some groups, we got this kind of feedback. So people were like, oh, I'm going on Instagram. Some people were like, I'm looking myself an article, but often it's maybe like more what I've tried myself. So this is like one of the things that we should actually explore as well. Or maybe like shape into like a more evidence-based one if we want more penetration of this knowledge in the community. And
First, I'm sorry again, just 1 minute too, because we
yes,
need to.
yes, perfect. And then last thing, there is like a lack of interdisciplinarity and inconsistent interdisciplinary protocol and lack of guidelines. So what I wanted to mention is, when we think from a clinical perspective, there was like, first of all, we think institutional support and individual support. When I talk with my colleagues, clinicians, they actually have a unilateral relationship where they do something and it has an impact on the patient. And the fact that nutrition acts indirectly and directly, but it's not seen, and directly involving, I should say, the power and balance, because when we support someone, there is a power and balance where we, as clinicians, think that we have a knowledge or a sentence or a treatment or something that we provide to someone. Nutrition is something like different. So it reverses, I have to say, the natural imbalance that exists in therapeutic relationship. And that's maybe a change of way of thinking as well, where the patient is actually like leading things under the advice of the clinician. And this is not what my colleagues actually mention. That they say like, well, we cannot control this. This is something outside of our scope. It's outside of the office. And I think we should think about that. Second, it's institutional. There are like a lot of limits that institutions are offering for clinicians. So they are like, this is not in my duties. So a changing and an evolving practice should work, and maybe identifying specific professions that could do like a bit of both instead of just like trying to find who is doing what would be like interesting. And the other way I wanted to think is like, what are I believe that the characteristics of the clinical relationship should actually help us to think how we can embed and change this barrier and challenges, because the clinician, when is offering advices or think about this, where has his trained or not, is still in a, how can I explain that, in a position where it doesn't have like a visual and an impact of his action right now, whereas a treatment is like 2 or 3 weeks, start to see signs, therapeutic effect, you sentence, you say something, it has an impact. So it's actually working without visibility. So it's one of the things that I wanted to talk about, because clinicians like to work when they actually see the feedback from the patient. And this is how we clinically are trained. We are working with the feedback and what works and what doesn't work. And we take 8 years for having this experience. Whereas nutrition, we don't have this feedback, except like 4 months later, where we actually used old therapeutic techniques or there are treatments associated. So there is a sort of confounding, and we cannot isolate only this pathway, nutritional pathway. Well, we can only do that if we have only one person, LCT, that do it outside of our perspective, or LCTs that isolate this. So I let this question, like how working on these characteristics could help to surpass these challenges. It's just an open questions, but I believe that could be like maybe the next step to explore this. Sorry, I hope I didn't do too long.
Thank you very much for this very interesting talk and lots of good food for thought. I think we have time for one question. If people want to put their hands up, otherwise I have one as well. I can start maybe. So you talk a lot about the different barriers to inform and train clinicians. What would be sort of the lowest hanging fruit you see in terms of setting up good training?
With training, I believe that it will be having access to dedicated training depending on type of professions. Because we ask assistant psychologists, psychiatrists, and sometimes they were referring to potential guidelines or some protocols or processes that have been thought, but the lack of visible, identified, and endorsed information by the professional body is actually what has been like mentioned the most. Even though there is like a new trend on this, I guess this should be like worked on. The first aspect, I guess, just to make it reliable for professional, because they say, I don't know what I do, but I try. So now it will be like, I know what I do, but I still don't know if it will have an effect clinically. And I think this is like the second step.
So we would need RCTs to test this. Okay, thank you. Are there other questions? I've seen some interesting comments in the chat about people developing training for the APA, I think, and so forth. Any other questions? Otherwise, maybe we'll leave it to the final round, and I'll hand over to Piril. Thank you very much again, Christoph.
You're welcome.
Great. Thanks both again. And our next speaker will be Dr. Caitlin Hall. Let me share my screen and I'll give some control to Caitlin, and hopefully she will be able to control the slides. But while I'll do that, I'll just briefly want to introduce Caitlin. She's the head of research at Myota. She's a neuroscientist and registered dietitian based in London. She holds a PhD in neuroscience and gut microbiology from the Queensland University and spent 2 years as a visiting researcher at King's College London. Her work focuses on the gut-brain axis, especially how variability in the gut microbiome influences brain network dynamics in anxiety and depression, and on how prebiotic fibers can support metabolic health, reduce inflammation, and influence mood. Let me try this. Okay, then hopefully you can move. Yep.
Let's see. Yes, it's perfect.
Perfect. Yeah,
Wonderful.
great.
Thanks,
Thank you.
Priscilla.
The floor is yours. Thank you.
Thank you. And yeah, lovely to be here as well for the first ever meeting. Today, I wanted to talk about some of the challenges and opportunities specifically for industry in terms of bridging the gap between research and practice, how we bring nutritional products and supplements to the market. So Piril's already done a wonderful job on my behalf, so I probably don't need to do any additional introduction for myself. So I'll jump straight to the opportunity in this space for industry. And it's pretty clear that, consumers are increasingly viewing functional foods and supplements as part of the toolkit for stress, resilience, focus, cognition, and mood. And this has been increasingly reflected in the huge market growth that we've seen in not only brain health, but also mood and relaxation supplements. We can see over here that while most trends in supplements have remained relatively stable over the past 8 years, mood and relaxation products are rapidly increasing, which reflects what we believe is that consumer demand. We think that there's 3 key trends or reasons why we believe there's a rapidly growing demand for foods and supplements with that brain and mental health benefits. The first one is that consumers actually have higher standards when it comes to products these days. They have access to more information, whether that's through traditional media or through social media, to learn more about nutrition, brain health, and the benefits of functional ingredients. There's also this emerging trend, which is we see consumers are driven to self-manage their conditions rather than exclusively rely on healthcare practitioners and their healthcare team. So people have been driven to seek more natural and non-pharmaceutical solutions to focus on prevention and also to be a bit more proactive in their health. Partially, this is driven by a overburdened healthcare system and also a consumer base that is continually dissatisfied with current treatment options. And we heard a little bit about that this morning in the previous 2 talks. And finally, there is evidence that there's a growing prevalence of poor mental health in the UK, particularly since COVID in 2020. So not only is there an increase in the prevalence across depression, anxiety, and cognitive impairment, but it looks like people are actually more open to talking about it as well, which is the silver lining. So people are more open to sharing their experiences with friends and family and potentially sharing their nutrition tips and, what products they're taking to support things like stress and mood and cognitive focus. So in terms of, the supplement space, which is predominantly where I'll be focusing on this morning, what are people actually taking? And it seems like consumers are taking supplements across 6 key areas for brain and mental health. This is an exhaustive list, but we see trends focusing on cognitive function, on mood, on focus and productivity, on sleep and stress, and sort of the other category, which is a blend of different functional ingredients. What I will be focusing a little bit on today, and goes back to what Myota is focused on from a research perspective, is prebiotics. So there is some emerging and some compelling evidence to show that prebiotics can have a role in supporting and attenuating cognitive decline, can improve mood, and also can improve stress. So for the next sort of couple of minutes, I wanted to give a brief case study into what Myota is doing to address these 3 key areas. And I'm sure everyone here is very much well versed around what prebiotics are, but for those who are new to the game, prebiotics are specific types of dietary fibers, so ones that cannot be broken down by the human gut, but instead serve as a food source for our beneficial gut bacteria. So as we consume prebiotic fiber, which is only found in specific types of foods like onion, garlic, leeks, asparagus, oats, green bananas, and artichokes, they are broken down by our specific fiber degrading bacteria to produce these really important substances called short chain fatty acids, or SCFAs. And this essentially is where we believe the growing demand for prebiotic fiber stems, is from short chain fatty acids' unique ability to target many different organs and biological pathways in the body, from supporting the gut lining to regulating inflammation, and then having knock-on effects through cognitive function, mood, stress, anxiety. Also some immune health and metabolic benefits as well. In terms of what Myota are doing to address this growing consumer need, we have produced a very diverse prebiotic fiber blend with the idea that it accounts for the vast differences that we see between different people's gut microbiomes. Most of us already know this, but there is huge variation when it comes to different people's gut microbiomes. No two people have the same composition or diversity of their gut bacteria. However, in most clinical trials that look at prebiotic ingredients, we often look at single ingredients. However, we know that between people, their ability to break that specific prebiotic fiber ingredient down and produce short-chain fatty acids like butyrate varies wildly between people. So as an example here, we can see 6 different individual fiber ingredients, prebiotic fiber ingredients, and the effect sizes on each of these can sometimes be huge. So take FOS, for example. Some people will produce very little butyrate when they consume FOS, others will produce a whole lot. This could be in part why we see huge variability in these clinical trials, almost a responder, non-responder type response when it comes to prebiotic fibers. So the early days of Myota was around building an understanding of different people's ability to break down fibers. And we studied, hundreds of different prebiotic fibers preclinically to see what the effects were across groups of individuals. From this, we were able to create sort of a blend of 9 different plant-based fibers so that we know any individual who takes this ingredient will reliably produce some short-chain fatty acids from the ingredient. In terms of the research that we're doing, we focus on 3 key areas: metabolic health, gut-brain axis health, and digestive health. But for the purposes of today, I'll only be focusing on what we're doing in the gut-brain axis space. So a couple of years ago, we ran a pilot study in 60 people with metabolic syndrome, and we gave them either the Myota prebiotic fiber blend, or we gave them the gold standard advice for dietary, which is the Mediterranean style diet. After 12 weeks of taking the blend, we found significant differences in inflammation as measured by CRP, as well as significant differences in stress and also in depression and anxiety scores in the treatment group versus the control group. However, this is a very small study and it's only scratching the surface in terms of how we can build a robust clinical evidence base. So from an industry perspective, building a credible evidence base is a marathon, not a sprint. So this is the gut-brain axis clinical pipeline for Myota, and it's a 4 to 7 year pipeline in progress. This is the study I was just mentioning earlier, which is our pilot RCT. We currently have 2 studies underway looking at cognitive function, and a 4th study who's just begun, which is looking at mild to moderate stress. We imagine another larger follow-up trial will be required after this to substantiate the claims in that earlier study. So it's a very long road for industry, and often we're studying the same endpoints again and again in larger sample sizes just to show that the results are replicated. So sometimes research and industry is not particularly, sexy. We just do the same thing again and again. That's all to lead into some of the major challenges that we face as an industry group when trying to bring a product to market in the gut-brain axis space. So there are many challenges. I'm only going to look at 6 of these today, which I deem to be more important and ones that we've currently faced at Myota. The first one that I wanted to talk about is scientific complexity. So this goes for any research area, but particularly for the gut-brain axis field. And typically we're studying 2 different systems together, the gut microbiome, and also the brain. Unfortunately, both are very noisy systems. Anyone who's worked with fMRI or with EEG understands that the data that you get is sometimes very noisy and hard to interpret. The same goes for anyone who's studied the gut microbiome, and we know that there's very noisy signal from both systems. So trying to see a really clear signal from very small population sizes and sample sizes is very complex, and there's huge inter-individual variability as well. In terms of the evidence, the mechanisms are becoming more clear, but they are incredibly complex. There's multiple pathways happening in parallel, and they're not quite fully understood yet. In a lot of academic and industry research, we often find that there's limited integration of multimodal data sets. So often we look at self-report improvements in stress, mood, and anxiety, but we're not often looking at the biological drivers of that. So the blood-based biomarkers, the brain-based biomarkers, which we can look at through fMRI. We're not also looking at things like, cognitive testing as well. This is something that we do need to do, and I'll go into a little bit more detail later around the regulation for this, but it's actually not incentivized in industry for us to do this. They often only want to see self-report subjective scales, which I think is ridiculous. In terms of any nutrition study, there's also interactions between diet, lifestyle, genetics, and the microbiome, which creates confounding factors. And generally, there is a lack of standardization in what endpoints we use across studies, and that goes from academia through to industry as well. It might reflect the fact that this is a really early research field as well, and those will come with time. The other thing is that industry likes to move fast and clinical trials do not. So the long timelines and the high costs do present a huge challenge for us. The next challenge, and probably the biggest one of the 6, is the regulatory hurdles. So in the UK, we are essentially governed by EFSA, so the European Food Safety Authority, and the UK FSA. It's kind of like a minefield working with EFSA though. So the evidence requirements to put in a EFSA health claim are incredibly strict. I don't think there's ever been a health claim for probiotics, nor has there been for prebiotics. However, there are about 20 for dietary fiber, which is good to see. It's very difficult, as it should be, to meet the clinical trial standards for subtle outcomes like mood and focus. And even if you do have that robust evidence base, the ingredient approval process can be really slow, especially if you're working for ingredients like novel foods. Then if you want to expand, if you want to leave the UK, the international regulations vary wildly. So it's really complicated when you're developing new products to keep in mind, not just the UK and Europe, but also the US, Canada, Australia, and beyond.
Caitlin, I'm so sorry, we are running out of time. So maybe 1 more minute, if you could wrap it up.
No problem.
Thank you.
I only got a couple more challenges to go. One being communication. So it is, once we do have the research, it's really hard to translate that complex scientific findings into clear, consumer-friendly language. And it's also a really sensitive topic. So for mental health, we don't want to risk communicating this incorrectly. The other challenge we want to look at is trust and credibility. So there's a lot of skepticism out there in the supplement market, a lot of snake oil products, a lot of products that do violate EFSA and the UK FSA and have health claims that they shouldn't. So making sure that we are being transparent in the research and telling the consumer exactly what they want to hear, but within the bounds is what we need to do. And then there's integration with HCPs, which we heard a bit earlier. 37% of UK adults who take supplements regularly consulted a GP or other healthcare professional. So making sure that we engage with HCPs and supplement brands to improve that trust and adoption in the clinical settings as well. And then I think this is the final one, which is research collaboration, which is the whole point of this meeting, is that while there are challenges working between academia and industry, once you find the right partner, it's a dream to work with them. Once you overcome, the funding challenges, the IP, the contracts, the timelines, finding that right academic partner is the most important thing for us as industry. So I guess to summarize, there is this huge increase from the consumer side to seek natural solutions. This presents a huge opportunity for us as an industry to develop those functional foods and supplements. But with that, there are still challenges in terms of regulations, scientific and credibility barriers, while still earning trust from healthcare practitioners and consumers. And that's all for me. Thanks, everyone.
Well, Thank you, Caitlin. This was a really great presentation, and it's really good to see that there are some industry partners out there who are willing to go above and beyond to generate credible evidence. Let me see if we have any questions to you in the chat. A question from Philip Murphy. Your product development pathway covered randomized control trials. Has the groundwork of systematic reviewing and meta-analysis been completed already?
Yeah, so all of our trials that we run are randomized control trials. They are all published in clinicaltrials.gov, and we actually register the studies with EFSA beforehand, so that if we do eventually submit any of the research that we build, then EFSA have been told that the results are coming. In terms of systematic reviews, we have done those in the past, but they're largely for internal use. There's really no necessary benefit in us publishing those, but all of our independent studies, our RCTs, are available online and published. So we, like, maybe some industry don't publish their results, but we put them all on clinicaltrials.gov and we publish all of our results.
Yeah, I can see that, Lauren, your hand is up, but we have run out of time, and I just want to pass the button to Dan to wrap up, because I am well aware that we couldn't finish our last activity, but please feel free to add it to chat, and I'll make sure that your question reaches to Caitlin. Thank you.
Thanks, Pil. Thanks, everybody. Yeah, really conscious of time, but I think we've had 3 great presentations there, coming from totally different angles as well, which I think is what this SIG is all about for me. You know, it's about building these collaborations. I can see from the chat there's been a lot of cross-talk, interdisciplinary discussion, which I think is really nice, and that's the kind of thing I want to encourage in this SIG. And the last part of this session was going to be a discussion. Obviously, we kind of run short on time, but I just want to draw your attention to the Padlet, which I've put a link to in the chat, and I'll just see if I can share my screen. Pil, can people see that?
Yes, I can see. Seeing nodding heads. Yeah.
Fab. So why have I done this? Why do we need another Padlet to complete? Well, the reason for this is that we want your input on where we should take this SIG, what we should do for the next meeting, and, you know, how we should move this forward. And that's what this is for. So if you can contribute, that'd be really nice. Our plan is to have another meeting before the end of the year, certainly, where we'll probably again aim to have the structure of 3 speakers, which are kind of based on what we've seen in the Padlet there, and potentially then another 1 or 2 next year, culminating in our first in-person meeting is the plan in September. So we'll obviously share more information about this as we go through the year. And, you know, and the topic and focus of that meeting at the end of the year will, of course, be driven by how we progress and things like that. So, yeah, please, really great to see everyone. And I'd really encourage you just to add some comments to the Padlet, and that will really help us moving forward. One thing I'm really keen to do as well is to encourage early career researchers in this field and early career staff as well, not just researchers, but people in other, you know, early career clinicians and people working in industry, because they're the future, and, you know, we need to get them on board and hear from them and see what they're doing as well. So I think I'm gonna, if people want to leave, of course, feel free to leave, but we'll hang around for a little while and we can have some discussion and answer some of the questions that have been put up. So yeah, thanks so much, everyone, and looking forward to seeing you all at the next event, and a special thanks certainly to the 3 speakers. So we'll hang around now. So is there any question? Does anyone want to pose some questions to these speakers that are still here? Please put your hand up. Lauren, you've been patiently waiting there. Thank you. Oh, you're on mute today.
Oh, sorry. Hi. No, sorry. Well, I didn't want to write it all out because I thought I'll end up blathering. But I just did have a question for Caitlin, if it's all right, if I can follow that up.
Of course, yeah.
So I was just wondering, I've worked in industry myself, so I know exactly the barriers that you're talking about, and the challenges. But some of the things that I'm curious about when it comes to some of these prebiotic studies, as well as the probiotic study, because we're working on probiotics ourselves, is a lot of the time, you know, we talk about these two integrated systems being extremely complex, and then we start to sort of drill it down to look at, we've got these few short chain fatty acids and link that to something like you did with butyrate. And I just wonder whether you've run any studies where you simply use as another arm butyrate or acetate or some of the short chain fatty acids directly to see if there's a benefit of your, you know, many different prebiotics compared to just providing the butyrate or the acetate directly.
Yeah, it's a really good question, and not something that we have done, although one of our collaborators has done a few studies where they've either, I think, directly given butyrate to the colon, or they've done butyrate capsules. And I think with the direct into the colon, they saw an effect of butyrate, but not necessarily from the capsules. The reason why we haven't done that arm, an additional arm using just, you know, a butyrate capsule so far, is largely adherence in those studies is often quite low, because to get a good amount of butyrate is a significant amount of capsules, I believe. And also they don't taste fantastic. So we've had really low adherence from other studies not looking at myota. But it's actually it would be a really nice comparison, an additional arm, to see what the difference is between, I guess, like the endogenous versus exogenous production of short chain fatty acids. It's a good idea.
Okay, thank you.
Thanks, Lauren and Caitlin, for that. I think there's some other hands up here. Laura Campbell, do you want to go ahead and speak?
Thank you so much. Sorry, this is another question for Caitlin. I don't know if anyone's ever aware I used to work with Ali and the other team at Nutritank, and basically they're an organisation that trains doctors. And what's very interesting, as I found from a medical point of view, is that there's this book called Bad Science, which talks about, you know, what was misinformation and what is good science. And they often refer to the Cochrane libraries as being the most trusted source of scientific information. And yet when I was doing my research recently, I couldn't believe how few of these nutritional psychiatry studies, even if they were gold standard randomized controlled trials and population representational humans, that didn't seem to translate across into the Cochrane libraries. And what I found is that created this distrust. It created this idea that, you know, this is very weak evidence, and that therefore that, you know, it's less rigorous, and you know, more of a, you know, kind of hippie bohemian fad, kind of like, along with herbs and spices and all of that, and yet we have so much comprehensive science there. So I was wondering, what from your perspective, what steps are we taking, and how can we as a group, you know, build up that trust with the healthcare professionals and get that shift? Because at the end of the day, if it's going to take 17 years, as we saw from the other thing, in order for that to have that clinical implication, and, you know, that literally will change lives. And that's what we're, at the end of the day, we're looking at here. You know, these research papers we do actually will translate into medical implication. And, you know, is there any way we can make that 17 years shorter? And I think the only way we're going to do that is if we get more in the Cochrane library.